the Mediterranean diet. And it's a fact that the origins of the Mediterranean diet are lost in time. If we dig back to the past, we may see that the Mediterranean diet or the dietary habits of the people living around the Mediterranean basin are historically oriented and starts up from the Middle Ages and mainly from the Romans that historical data says that the Roman tradition was identified in bread and wine and oil products, sheep cheese, vegetables, very little meat, and strong preference to fish and seafood. This was for the Romans a symbol of rural culture and agricultural. But beyond the Romans, the story about diet and human health starts from the Hippocrates. Hippocrates said that let food be the medicine and medicine be the food. And if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. In few words, Hippocrates, 2,500 years ago, described what we say here about primary prevention of cardiovascular disease through lifestyle. It's known that food has always been an important part of health, and the olive was, and we believe that remains, at least for the Mediterranean region, a chief healthy agricultural product in our region. Historically, the Romans used the olive tree to reclaim land, basically, and together with vine and domesticated wheat, the olive supported the development of civilization in our areas, in the areas of Aegean Sea and the Mediterranean Sea. Food has always been an important part on health as well in Greece. Evidence of olive cultivation in Greece dates back 3,500 years ago. Today, the Mediterranean basin produces approximately 99% of the world's olive oil, of which people of the region consume approximately 87% based on the most recent data we have. But it's not olive and olive oil. Beyond olive and olive oil, we have large quantities of vegetables and fruits supplement the dietary habits of the people living in the Mediterranean islands. Historically, and regarding epidemiologic evidence, we would like to believe that the story starts from this man, Ansel Keys, and the 7-country study. He is the one that first described a Mediterranean dietary pattern close to what we call now Mediterranean diet, and revealed the beneficial effect of this dietary pattern on human health. Based on a study, a historical study for cardiovascular epidemiology, the 7-country study, that included approximately 12,000 men ages from 40 to 59 years old from 16 cohorts and 7 countries around the world, Ansel Keys revealed that in the first 10 years and in the first 25 years of the follow-up of this study, the Crete cohort, the cohort of the Greek rural Crete areas, had the lowest mortality rate from cardiovascular disease, following by the Japanese cohorts, as we can see here. If we go into the insights of the 7-country study, we may easily see the differences in the dietary habits of 3 well-representative cohorts of the study: the United States cohort of the 7-country study, the Zutphen in the Netherlands cohort of the 7-country study, and the Crete cohort in the Crete Islands of Greece. We can see differences in bread consumption, in legumes consumption, in fruits consumption, as well as in olive oil. As we can see here in this slide, olive oil was unknown for the United States cohort and the Netherlands cohort, the Zutphen cohort. As well as we can see here, the very reduced consumption of meat in the Crete cohort as compared to the other cohorts. Similarly to the meat consumption, we can see here also the reduced consumption of sugar products and pastries. But we can see also here an amount of alcohol drinking that was translated to 1 or 2 glasses per day, especially from wine, red or white. However, one of the most historical data and historical observations of this 7 countries study, I believe, is this one, in which in 1995, Dan Kromhound and his colleagues reported a clear linear relationship between coronary heart disease risk and average saturated fat intake. Here are the cohorts of the study. These are the Japanese cohorts. This is Creta in Greece, and these are the other studies. Cohorts. As we can see here, the higher the average saturated fat intake, the higher the 25-year coronary heart disease risk. After these years, many people attempted to describe the Mediterranean dietary pattern. One of the most widely accepted definitions of the dietary pattern is this one. It's called the Mediterranean diet pyramid, presented in Greece by the end of 90s by Antonia Trichopoulou and other colleagues. Mediterranean diet, as we may all know, is a diet that consists of daily use of olive oil, increased consumption of fruits, vegetables, grains, cereals, and fish, and rare consumption of meat and products. More recently, a few years ago, Backfaged colleagues, based on the observations of the other Mediterranean region countries, including France, Spain, Italy, and Greece as well, reported a similar diet pyramid named the Mediterranean diet pyramid, with exact servings as we can see here. This is now considered the most recent definition of the Mediterranean diet. In 2013, UNESCO inscribed the Mediterranean diet on the representative list of the intangible cultural heritage of the humanity. This was the greatest honor of dietary pattern and of those that were working on this field on diet and human health. UNESCO reporting that the Mediterranean diet involves a set of skills, knowledge, rituals, symbols, and traditions concerning crops, harvesting, fishing, animal husbandry, conservation, processing, cooking, and particularly the sharing and consumption of food. So we have a quite different definition of what UNESCO believes that is the Mediterranean diet in our days. Eating together is the foundation of the cultural identity and continuity of communities throughout the Mediterranean basin. In our days, there are many studies looking on longevity and very older people, suggesting that eating together is one of the secrets of living longer. We have to adopt that the Mediterranean diet has great variations around the Mediterranean basin. Also, we have to adopt that Mediterranean diet was found not only in Greece, Italy, Spain, and France, but as well as in Libya, in Egypt, in Algeria, in Morocco, and other countries. Beyond the 7-country study, there are several other epidemiologic studies, reported evidence, strong evidence about the benefits of the Mediterranean diet on human health. One of the studies that focused their attention on the effect of Mediterranean diet on mortality was the EPIC Greek cohort. The EPIC study reported a few years ago in New England Journal of Medicine that a small increase in a diet score that evaluated adherence to the Mediterranean diet, even 2 out of 9 increase of the score, was associated with almost 25% reduction in all-cause mortality and almost 33% reduction in cardiovascular disease mortality. Mediterranean diets seems to be appropriate for human health not only in middle-aged people, but even in older adults, and the health study, a multidisciplinary approach, including 11 European countries around the world, reported similar findings. The higher the adherence to the Mediterranean diet, the lower the risk of coronary heart disease, cardiovascular diseases, as well as cancer and other causes. One study that I had the honor, together with Professor Pitsavos, to supervise was the Cardio 2000 study. It was a nationwide Greek study, a case-control study, that reported that greater adherence to Mediterranean diet was associated with lower risk of having an acute coronary syndrome, a cardiac event, fatal or non-fatal. This was one of the first studies that also evaluated non-fatal events, and this effect was similar even in rural or urban areas of Greece, and as well as similar among hypertensive people, diabetic people, dyslipidemic, or those adopting a sedentary lifestyle, or obese people. It was not significant only among smokers. Smoking seems to postulate the effect of Mediterranean diet. The Attica epidemiologic study was one of the first studies trying to go to in the sides of the Mediterranean diet and to the mechanism that Mediterranean diet may benefit human health. In this paper, published in JACC 10 years ago by Kresoho and colleagues, was first reported the effect of Mediterranean diet on a variety of inflammatory and coagulation markers, as we can see here. Again, from the Attica study, in the 5-year follow-up, reported that greater adherence to the Mediterranean diet, even 1 out of 55 units increase in the diet score we use, there was a 6% reduction in cardiovascular disease risk. But Mediterranean diet and epidemiological studies are not only based in the European or the Mediterranean region. A paper recently published in Archives of Internal Medicine, based on the data from the NHANES study, reported that greater adherence to Mediterranean diet was associated with lower risk of all-cause mortality and cardiovascular disease mortality in many subgroups, in men and women, in smokers and never smokers. Seems that Mediterranean diet may benefit human health not only in Mediterranean or European populations. The last 10 years, several investigators attempted to systematically review the evidence, the epidemiological evidence of Mediterranean diet on human health and cardiovascular disease. This is a first attempt 10 years ago, reporting several observational epidemiologic studies and the effect on cardiovascular disease risk. As we can see here, all studies included in this review showed a significant protection of the Mediterranean diet on cardiovascular disease, mainly on acute coronary syndromes. What we have to notice is the very few studies available by that time, but however, a more recent meta-analysis published in BMJ by Francesco Soffi and colleagues also confirmed the previous systematic review results, showing a greater adherence to Mediterranean diet associated with lower risk of all-cause mortality and cardiovascular disease mortality. Again, we have to notice that there are very few studies available in this meta-analysis too. The majority of the studies presented in this presentation now were based on the first event of a cardiac event. However, Mediterranean diet seems to be appropriate not only for primary prevention, but for secondary prevention as well. In another observational study, we had the opportunity to supervise the Greek study. We reported that greater adherence to this dietary pattern was associated with lower risk of a secondary cardiac event among people that already had an acute coronary syndrome. All these epidemiological studies, however, several basic research studies revealed potential mechanisms regarding the effect of Mediterranean diet on cardiovascular disease risk. And the pleiotropic effects of Mediterranean diet include the antioxidant effect, the anti-inflammatory effect, as well as low glycemic index of this diet, and that may be able to reduce insulin resistance. We have stated recently another hypothesis about the effect of Mediterranean diet on cardiovascular disease risk. And this hypothesis is based on an observation we have made that Mediterranean diet adherence is associated with lower body mass index and lower likelihood of being obese or overweight. So it could be a path that includes Mediterranean diet, obesity status, and cardiovascular disease risk. And thus, we stated a new hypothesis that should be further investigated by other clinical studies in the near future regarding that the effect of Mediterranean diet may go independently through the effect on body mass index. In a recent meta-analysis we published in 2011, we can see that Mediterranean diet seems to be appropriate for reducing the risk of having metabolic syndrome as well as its components. So, in conclusion, the epidemiological evidence suggests that Mediterranean diet protects against the development of cardiovascular disease as well as diabetes and hypertension, not only because of the pleiotropic effects mentioned before, but also due to a possible effect on body weight and obesity status. As food for the discussion at the end of the panel, I have to raise now two important questions. Is the Mediterranean diet an integral entity or the sum of components that can and should be separately considered? In my lecture several times I have been asked, is it so important the whole dietary pattern or olive oil or fruits and vegetables or cereals? Another question, very important, is that is the Mediterranean diet or its components transferable to other populations living away from the Mediterranean area, or the Mediterranean diet seems to benefit only the Mediterranean people? At the end, I would like to point out that even the Mediterranean populations now seems to be away from this traditional dietary pattern. We had the opportunity to evaluate the dietary habits of the Greek people the last 10 years, and approximately 40 to 50% of the people are away from the traditional Mediterranean diet, seems to be close to what we call westernized diet. So what we need now and what we need to project for the future generations is we need nutrition education. We need to educate our children to follow the diet of our ancestors. And efforts should be made not only from the practitioners, but also from the policy makers. The European Union should focus on dietary strategies in order to improve the health of the community in Europe. Thank you very much for your attention.
I will take the lead after the excellent overview by Professor Panagiotakos, because he already laid down the principles on which my presentation will be built on. No conflicts of interest for this presentation, and he already summarized what are the critical components: a diet that is poor in calories, rich in complex carbohydrates with a low glycemic index, rich in fiber and vegetables, also rich, I will dwell on this, in alpha-linolenic acid and in some areas of fish-derived icosapentanoic and docosahexaenoic acid, usually rich in oleic acid that comes from olive oil, with a moderate consumption of alcohol, especially from wine, and also at the end rich in antioxidants from the extra virgin olive oil, including this compound, quercetin, hydroxytyrosol, linoleic acid, and transresveratrol, this latter mostly coming from red wine. I will dwell specifically on 4 items, and I try to lay down what are the effects of these selected components. So I will dwell on the components of vegetables in the Mediterranean diet and what might be one important reason by which vegetables contribute to the beneficial effects. Vegetables are an important source of nitrates, and this has emerged in the past years as an important mechanism, potential mechanism for beneficial effects. You see here a classification of vegetables according to the nitrate content, and you see that some vegetables, including rucola, some types of lettuce, red beetroot, spinach are extremely rich sources of nitrates. Now, you are mostly familiar with the hypothesis that led to the Nobel Prize more than 15 years ago now, with nitric oxide as a bioactive mediator promoting vasodilation, inhibition of platelet aggregation, and also inhibition of the early steps of atherogenesis by blocking endothelial leukocytes interaction. But besides the well-known L-arginine nitric oxide pathway that we have been familiar with for the past 15 years, there is another source of nitric oxide that has been mostly identified in the last 4 or 5 years, which is the pathway that leads from dietary nitrates to nitric oxide, that mostly takes place in conditions of hypoxia and takes a path that has been only recently identified and characterized. This is the so-called entero-salivary cycle of nitrate as a source of NO, and it all starts with dietary nitrates that we ingest, especially when a diet is rich in vegetables. Nitrates are absorbed from the stomach and the small intestine, and then concentrate in the salivary glands, where lingual bacteria may reduce nitrate to nitrite, and the acidic environment of the stomach again can reduce nitrate to nitric oxide, and in this case nitric oxide may diffuse into the portal circulation and be transported also to the arterial circulation, where it exerts its biologic effect. And as a matter of fact, there has been evidences from investigation, in vivo investigation, that measuring nitric oxide levels in the blood can be affected by the amount of dietary nitrates. I will next dwell on a second component, that is the abundance of alpha-linolenic acid and, as I said in parentheses, in some areas of fish-derived eicosapentaenoic and docosahexaenoic acid. As you know, there are two main classes of polyunsaturated fatty acids: the linoleic series, or omega-6 series, and the alpha-linolenic series, or the omega-3 series. And the two series are not interconvertible in mammals, so basically what we get from our food is what we can elongate, and we can actually elongate linoleic acid to arachidonic acid. That is the main source of usual prostaglandins and leukotrienes. But we can also use alpha-linolenic acid from the diet to produce elongated products to a limited extent, which are eicosapentaenoic acid, or 25 omega-3, or docosahexaenoic acid, which is the most elongated product, which has 22 carbon atoms, 6 double bonds, the last of which is in the N-3 positions. Now, most of research on this has been revolving on the positive effects of EPA and DHA, but we have to acknowledge that there is also substantial evidence that alpha-linolenic acid that we can derive from vegetables can also contribute to some of the biologic effects of these omega-3 classes of substances. Alpha-linolenic acid itself appears to be a modest source of longer chain omega-3 fatty acids because there is a limited ability of our body to elongate, and there is also a competition with the linoleic acid for the delta desaturase activity that is responsible for the elongation of alpha-linolenic acid into EPA and DHA. So I will ask the question, do typical Mediterranean dietary patterns provide appreciable and biologically meaningful increases in plasma levels of omega-3 PUFAs? And we have data from, in this case, from a Dutch cohort and from a multinational cohort coming from Spain, Portugal, Italy, and Greece, that shows that Greeks, for example, have much more alpha-linolenic acid and lower linoleic acid than the Dutch. This is, revolves on the idea that alpha-linolenic itself may be associated with protection, and also on the fact that the consumption of fish is very irregular and dishomogeneous according to the source of investigation within the Mediterranean basin. Nonetheless, a positive association has been found between spontaneous adherence to a Mediterranean dietary pattern as assessed by dietary score and plasma DHA and EPA in both the Etica cohort and in the 3CT cohort studies. And also in an intervention study, the administration of a Mediterranean-type diet to healthy subjects has resulted in a notable, about 50% increase in DHA plasma content compared to an ordinary Swedish diet. So we have to acknowledge that we can have some of these effects brought about by the consumption of alpha-linolenic acid and to some extent by the most elongated products that are EPA and DHA. And I borrow this illustration from the Predimed study that most likely Professor Estruch will discuss later on, showing that one of the arms of the Predimed study was the Mediterranean diet rich in nuts, which are themselves very much rich in alpha-linolenic acid, and this was associated in an intervention study, important primary prevention intervention study, with a substantial reduction in morbidity, mortality from cardiovascular disease compared with a controlled diet. And we know that we have multiple ways of action of omega-3 fatty acid that have to do with atherogenesis, the growth and the complication of plaques, thrombosis, and arrhythmias. And just to remind some of our own research on this is the effects of docosahexaenoic acid, the omega-3 docosahexaenoic acid, in a classical assay of leukocyte endothelial adhesion, by which you see that when you have an inflamed endothelium, such as here, in this case by interleukin-4, but you can do it with the TNF or interleukin-1, by exposing endothelial cells to docosahexaenoic acid in order to have an enrichment of these fatty acids in plasma membrane of the endothelial cells, you can substantially quench the pro-inflammatory profile of endothelial cells. And this has likely to do with an interference with the activation of what we consider nowadays the engine of atherosclerosis and inflammation, which is the NF-kappa B system, which can be downregulated because docosahexaenoic acid and in general omega-3 fatty acid interfere early on with the signal transduction cascade that is elicited when interleukin-1 hits its membrane receptor, eliciting a chain of events that eventually culminates in the expression of adhesion molecules, increased leukocyte adhesion, increased endothelial inflammation. Let me now dwell a little bit on the component of oleic acid that is also extremely rich in olive oil. And here, monounsaturated fatty acids may exert two broad set of effects. One is the competition with the saturated fatty acids in quenching the generation of reactive oxygen species, and I will give you some evidence for this, and also on the effect that oleic acid and MUFAs in general may have effect on postprandial triglycerides and on thrombosis that may be associated with the increase in postprandial triglycerides. This slide shows what happens to an endothelial monolayer when you inflame it with TNF in this case, and the intensity of the color depicts the amount of generation of reactive oxygen species, mostly hydrogen peroxide within endothelial cells. And you see that you can quench this to a large extent with the omega-3 fatty acid, docosahexaenoic acid, but also to some extent with the monounsaturated fatty acids. And here we most likely have an interplay of competition between saturated fatty acids that are pro-inflammatory and increase the generation of reactive oxygen species and the quenching effect of oleic acid. But also we have the other effect of oleate-rich diets that has to do with the postprandial increase of triglyceride, the so-called postprandial hyperlipidemia, that is associated with a substantial increase in coagulation factor 7 antigen and activity. So there is both measurable increase in the antigenic portion of factor 7 and in the part of factor 7 that is activated and can start the extrinsic coagulation cascade. And diets rich in oleate sharply reduce the ability of triglyceride-rich lipoproteins, which are mostly chylomicrons, to promote the cleavage of the inactive factor 7 to the active factor 7A. And these slides depict the pathway and the point of action of oleic acid in quenching the generation of active factor 7. And then last piece of evidence that I want to give you is where most research has revolved in the past 10-15 years, the reach of Mediterranean diet in antioxidants from extra virgin olive oil, quercetin, hydroxytyrosol, linoleic acid, and resveratrol. Antioxidants are rich in olive oil probably because of the exposure of the fruit of the olive tree to the sun, and there is a particular abundance of these polyphenols in olive oil and also in grapes that are exposed to the sun of Mediterranean regions. And dietary polyphenols again and again can reduce the generation of reactive oxygen species when endothelial cells are challenged with a pro-inflammatory stimulus, and can reduce nuclear factor kappa B activation. And this may also lead to effects on the downstream consequences of NF-kappa B activation. For example, the increased activity of cyclooxygenase 2 in plaques and metalloproteinases that are thought to be linked to the destabilization of atherosclerotic plaque and possible plaque rupture. And then we have a host of effects of these polyphenols on platelet function that may lead to anti-thrombotic benefits. These were recently reviewed in this nice review by Gemma Villahour and Lida Badimon in Vascular Pharmacology 2013. So we have multiple mechanisms of action of natural dietary substances in Mediterranean diets, mostly related to their ability to inhibit gene expression of pro-inflammatory genes, inhibiting redox-sensitive transcription factors, inhibiting factor 7A trigger thrombosis, and also, which I didn't treat in these minutes, to inhibit arrhythmogenesis, that is an effect mostly ascribed to long-chain omega-3 fatty acids. And I want to leave you with this question: will we be able to ever put this magic cocktail in a pill for the skeptical cardiologist? Thank you very much for your attention.
For some nice words. I thank you for the organizers to give me the opportunity to explain here our research. And we will divide the few minutes we have from the talk to talk the half about Mediterranean diet and the polyphenols in Mediterranean diet, and the second half about the polyphenols effects of wine on health. So we want to speak about one of the main causes of death in the 21st century. So we have to fight with against cardiovascular disease with all our weapons, and we know that the best weapons we have, or the first weapon we have to apply to our patients, is diet and exercise. The problem we have, I am a clinician who am working in a teaching hospital. Sometimes we don't have enough time to teach our patients to improve the diet, to practice more exercise, etc. And maybe it's easier to prescribe or to give a drug like statins or whatever. What we have learned in our studies is that diet has a very, very powerful effect on protecting against cardiovascular disease and without side effects. So we have to maintain our principles and to start when we have in front with a patient to try to improve their diet, to recommend them to get more exercise, and if this is not enough, we can go to the drugs. So we have to maintain the principles of the diet and exercise as the first step in the treatment of cardiovascular disease. With this aim, we designed 10 years ago the study we call PREDIMED, in Spanish is Prevención con Dieta Mediterránea, to assess the effects of Mediterranean diet on primary prevention of cardiovascular disease. This study has been a very hard work, has been working around 18 teams from Spain, from around Spain, and we were able to include in the trial near 7,500 participants, high-risk participants, who were divided in 3 groups. One has to follow a low-fat diet. This is the more standardized treatment for this, or dietary treatment for these patients, and another group to follow a Mediterranean diet plus olive oil, and the third group a Mediterranean diet plus nuts. So the primary aims we have was to test the effects of Mediterranean diet with extra virgin olive oil on the risk of cardiovascular disease. The second aim was to test the effect of Mediterranean diet supplemented with nuts, with a mix of walnuts, almonds, and hazelnuts, on the risk of cardiovascular disease. And one of the key of our study was we measure hard endpoints. So we measure a composite endpoint of cardiovascular death, myocardial infarction, and stroke. And this is the strength of our study. We are also want to test if the effects of moderate wine on the risk of cardiovascular disease, but in this case it's not a randomized study, so they lose the strength of our recommendations. So we have to remind that we're fighting against cardiovascular disease and fighting the very hard endpoints like cardiovascular death, acute myocardial infarction, and stroke. And this is the main figure of our study that Professor Caterina told we published in New England last year, and you can see here that the incidence of cardiovascular events in these high-risk patients was increased throughout the study, and this is the incidence in the control group, and this is the incidence in green line in the group of Mediterranean diet plus extra virgin olive oil, and in yellow is the incidence of cardiovascular events in the group of nuts. We have to stop the study because the DSMB of the trial told us that it was unfair to continue because the control diet has higher than 30% of higher relative risk of cardiovascular events than the other arms treated with Mediterranean diet. So we have to stop the study because of the powerful effect of Mediterranean diet against this cardiovascular disease. And this is important that we have measured the adherence to Mediterranean diet using a 4-point score, and this was not a very high, very big changes between the groups. So you can see here the score, it was an average start more or less 8.5, and this is more in the control group was somewhat increased throughout the study because of contamination. And you can see here we were able to change the dietary habits results of our patients and to upgrade the score in 2 points, no more than 2 points. And you can see here that there is now a big change in the dietary habit, but this is enough to get a very, very strong results, like a reduction of 30% of relative risk on cardiovascular disease. So maybe it's difficult to change the dietary habits of our patients, but we are able to change a little. This is really has a very important effect, because we eat 3 to 5 times a day, every week, every month, every year. So the effect of the diet it's really very, very powerful, and little changes are able to get a very big results. So, and we tried to look for some mechanisms by which Mediterranean diet may exert this protective effect. And one of the mechanisms we thought was the polyphenols, and we measured the total polyphenol in urine, and we were able to show that in the both groups from Mediterranean diet was a significant increase in the total polyphenols excreted in urine compared to the control group. So we realized that Mediterranean diet is very rich in polyphenols, and these polyphenols had been absorbed by the participants and was excreted by the urine. So we have to see that polyphenols may play a role in the effects we have measured. We also measured the polyphenol intake according to the food frequency questionnaire, and we divided in this case was the cohort we have explained it, with low intake of polyphenols, medium intake of polyphenol, or high intake. That was a high intake higher than 550 milligrams a day, and you can see here the probability of death was really very, very different between the people who was with low. The survival was the people who has a low intake of polyphenols compared with the people who has a high intake of polyphenols. And when we separate the different subclasses of polyphenols, different groups, we saw that stilbenes that came mainly from red wine, and lignans who came preferably or mainly from olive oil, was one of the key polyphenols that may explain these differences between the groups with survival. So we think that polyphenols may play a role in the protection against cardiovascular disease, polyphenols intake during the Mediterranean diet, and maybe these subclasses of polyphenols may play a role. But what about wine by itself? You know that there are several studies that have analyze the effects of moderate alcohol consumption in the protection of cardiovascular disease. This is one of the meta-analyses of the latest meta-analysis. You can see here was a reduction. The people who drink about 13% of reduction in moderate drinkers. And when we try to separate the effects of the different types of alcoholic beverage, we can see here was the separation between wine and beer, and in this meta-analysis published in Circulation in 2002, they were able to assess a reduction of cardiovascular risk with wine with a reduction of 32%, and the beer of 22%. But in the latest meta-analysis performed and published 3 years ago, the protection of wine consumption or beer consumption was quite similar. That this is very strange for me, but this is the result of the meta-analysis, suggesting that there's no difference between wine consumption and beer consumption in the protection against cardiovascular disease. But we think that this is come from epidemiological study. It's very difficult to measure the alcohol consumption in the big cohorts, and it's also very difficult to differentiate the effects of wine or beer or spirits on these effects. So maybe we can go to another kind of studies that would allow us to better measure what the people drink, and to analyze some biological effects of protection against cardiovascular disease. And when we analyze the possible mechanisms of the beneficial effects of moderate alcohol consumption, we saw that some mechanisms are related to the arterial lesions, increased HDL, reduction of LDL oxidation, changes in the endothelium, improving insulin sensitivity, and also prevention against arterial thrombosis, reduction platelet aggregation, inhibition clot formation, or activity in the thrombotic system. But we are interested to know which could be the effect of this moderate alcohol consumption. So we know that wine, as also beer, has two main components. One is ethanol, and the other is the phenolic compounds. So in this sense, we designed different types of studies, randomized prospective crossover clinical trials, comparing the effects of one alcoholic beverage with other alcoholic beverage, one alcoholic beverage rich in polyphenols, like wine, or to compare it to an alcoholic beverage without polyphenols, and we have measured that would be gin. So one of our reasons to design is we decided an alcoholic beverage who has alcohol plus polyphenols compared with another alcoholic beverage with only alcohol without polyphenols like gin. And we measure different parameters related with inflammation, and we measure lymphocyte and monocyte adhesion molecules and chemokines, and you can see here the list of the adhesion molecules we have measured. And we are also very interested in to measure also the addition of these cells in the endothelium, and this is the first step in the development of atherosclerosis. You can see here that the leukocytes has to go through the endothelium, and they plays a role the selectins, a small rolling with integrins, and possibly a firm addition and transmigration inside of the endothelium and start the atherosclerotic progress. In this sense, we have measured this in a crossover study, these adhesion molecules in lymphocytes and monocytes in the people after drinking or having gin. This is an alcohol, no polyphenols, compared to wine. This is an alcoholic beverage plus polyphenols, and you can see here was a very significant reduction in most of the addition molecules we have measured, like BLA4, on these other from monocytes, LFA1, MAC1, BLA4, and MICP1. So you can see in this trial we were able to demonstrate that wine has an anti-inflammatory effect, mainly due to polyphenols, because gin was unable to have this anti-inflammatory effect. So our hypothesis is that the anti-inflammatory effect of the alcoholic beverage is due to polyphenols. We know that we can measure also in plasma another kind of inflammatory markers like BCAM, P-selectin, MCP1, etc. And we also saw that was a reduction, mainly reduction when the people drink an alcohol plus polyphenols. In this study we published some years ago, we compared gin versus cava. Cava is the Catalan champagne, so it's a white wine. And we also measure in these studies the different parameters of oxidative stress, like malondialdehyde, etc. And we also saw that when the people drink alcohol plus polyphenols, in this case was red wine, was the effects was more greater than when the people drink only gin. But we go further and we try to analyze the capacity of the addition of the monocytes to an endothelium before and after the intervention, before and after to drink alcohol like gin, or before and after to drink alcoholic beverage like wine. And so you can see here was after the intervention period with gin was a decrease in this capacity of addition of the monocytes to endothelial cells around 40%, but after the drinking the wine, so the alcohol plus polyphenols, was a reduction in this capacity of addition around near 100%. So again, this was a very different in the functionality of these cells after drinking gin or after drinking wine. This is an example. This is the addition at baseline. We stimulate with TNF-alpha, and this is after the washout period. The number of monocytes had been adhered to the endothelial layer, and after gene there was a reduction, but was a much more reduction after red wine. Is a visual example of the data I have presented. But we go further and we try to better analyze the effects of polyphenols, and we compared red wine, this is wine with polyphenols, the alcoholized red wine, this is more or less only polyphenols, and gin, this is more or less alcohol without polyphenols in another crossover design, and after around 1 month of intervention, and to drink in more or less 30 grams a day of alcohol in form of red wine or in form of gin, and the same amount of polyphenols of red wine in form of the alcoholized red wine. And you can see here that in some parameters of inflammation was changes the same in red wine and in gin interventions. We have to say that these changes have to be attributed to ethanol, because was the same in red wine and gin, was an increase of serum interleukin 10 and was a decrease in serum monocyte derived chemokine. So alcohol by itself are able to have some anti-inflammatory effect, but when we measure another parameters like IPCAM1 or interferon 1 alpha or interleukin 6, was the same reduction after red wine, after the alcoholized red wine. So we have to attribute these effects to the polyphenol, because it was the same in red wine and the alcoholized red wine. We measure also another parameters. We measure, for instance, insulin and the HOMA index, and was a significant reduction after red wine and the alcoholized red wine without changes after gin. So we think that polyphenols plays absolutely a role in the prevention of diabetes, of diabetes in Mediterranean diet or with wine drinkers, because was the same after red wine and was the same after the alcoholized red wine, and was no changes after gin. When we analyze HDL or LDL-HDL ratio, this was different, because in this case the changes have to be attributed to ethanol, because we saw the same effect after red wine and after gin without changes after the alcoholized red wine. So part of the effects of the alcoholic beverage have to be attributed to polyphenols, like this on insulin sensitivity, or another effects have to be attributed to alcohol, like this on the lipid profile we analyze. And we analyze also what happened with blood pressure. We were able, was more or less a small decrease after red wine, was a very significant decrease after the alcoholized red wine in systolic blood pressure. There was no change after gin. It was a significant decrease after the alcoholized red wine in diastolic blood pressure. So again, polyphenols may play a key role in reduction of blood pressure. And when we measure nitric oxide, we saw an increase of nitric oxide only after the alcoholized red wine. So in this case, this effect has to be attributed only to polyphenols, and alcohol do not play a significant role in the nitric oxide we measure in plasma. We also measure some correlations, and again, the best correlation between changes in nitric oxide and changes in systolic blood pressure and diastolic blood pressure was observed after the alcoholized red wine. So polyphenols really play a role in the protection against cardiovascular disease. So we know the alcoholic beverage, and we know that wine is an alcoholic beverage, has negative effects mainly due to ethanol, and if you drink a lot you may have a liver cirrhosis or diabetic cardiomyopathy. But if you maintain a moderate consumption of mainly alcoholic beverages plus polyphenols, you were able to reduce your mortality, to reduce the risk of cardiovascular disease, Alzheimer's disease, etc. So this is our consumption. It is very important to maintain a high intake of polyphenols. The polyphenols plays really a role when we measure in the diet and also with alcoholic beverage. And some of the effects of the red wine have to be attributed to polyphenols and some of the effect to ethanol. But the main effects we think it's due to polyphenols. Thank you very much.